for everybody to join us in this series of lecture in cardiovascular disease for the medical student. Our lectures of today is the aortic valves, aortic regurgitation, mainly classified aortic regurgitation or aortic incompetence into the acute and chronic presentation. Our main goals and objective of this lecture to discuss the common etiology of the aortic incompetence, recognize signs and symptoms of severe aortic regurgitation, be able to quickly identify acute type of regurgitation, and be able to identify patients who should be referred for the surgical valve replacement. The main goals are to know etiology, pathophysiology, and hemodynamic change, and the proper physical examination, to know the natural history of the aortic regurgitation, and the most important and physical investigation for diagnosis, and to put proper plan for the management. And this is a diagram and echo, left parasternal long axis view, to show the regurgitant volume in the left ventricle. Definition of aortic regurgitation are leakage of blood into the left ventricle during diastole due to the ineffective, improper coaptation of the aortic cusp. This is the first picture. This is the cusps. This is the left coronary, right coronary. There is another non-coronary valve. Improper coaptation during diastole, for the blood is regurgitant from the aorta to the left ventricle. This is the regurgitant volume. In acute aortic regurgitation, really the most common cause of endocarditis, and aortic dissection is the second most common cause. During physical examination, while pulse pressure is important, diastolic murmur and the fluid, acute pulmonary edema. Acute aortic regurgitation, in fact, is a true surgical emergency. Before surgery, put a patient positive inotrope like dopamine, dobutamine, vasodilator like nitroprusside infusion, avoid beta blocker, and don't think about and don't even consider balloon pump counter pulsation in acute aortic regurgitation. This is gross pictures for acute aortic regurgitation with a fenestration hole and there for in the aortic cusps. Etiology of a chronic aortic regurgitation: bicuspid aortic valve, the most common cause, rheumatic heart disease, and infective endocarditis. The pathophysiology and hemodynamic change: aortic regurgitation, in fact, is a combined of pressure and volume overload. The compensatory mechanism of aortic regurgitation: left ventricular dilatation, left ventricular hypertrophy, progression of dilatation until the left ventricular function decline and the heart failure develop. In the natural history of aortic regurgitation, it's asymptomatic the patient until fourth and fifth decade. A rate of progression, this means from asymptomatic to symptomatic, every year 4 to 6% per year becomes symptomatic. What the progression of progressive symptoms, these include dyspnea, nocturnal angina, and chest pain or palpitation, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, nocturnal angina due to the slowing of the heart rate and reduction of diastolic pressure during night, and palpitation due to the increased force of contraction. Physical examination and finding of aortic incompetence: wide pulse pressure is most sensitive, hyperdynamic and displaced apical impulse. During auscultation, three findings: diastolic murmur, Austin Flint ordo diastolic murmur at the apex, and the systolic ejection murmur. Diastolic blowing murmur at the left sternal border, while diastolic rumble, Austin Flint apical at the apex, is the regurgitant jet of blood is impinged on the anterior mitral leaflet, causing to vibrate and give the Austin Flint murmur. Systolic ejection murmur due to the increased flow across the aortic valve. There is a lot of auscultatory and peripheral finding in severe aortic regurgitation, and put them in a simple glossary and eponyms of these to be simplified. Sign and description. Austin Flint murmur is a low-pitch apical mid-diastolic murmur. Corrigan sign or Corrigan pulse, high amplitude, abrupt collapsing pulse. Drozier signs to and fro brewing over the femoral artery. While Hill sign, more than 40 mm of mercury differences between popliteal and brachial pressure. Mayan sign, more than 15 mm of mercury drop in the systolic blood pressure with arm elevation. Tropy sign, loud systolic or pistol shoots over the femoral artery. Quincke's pulse is exaggerated reddening or blanching over the bed nail or nail beds. Molar signs, the visible pulsation of uvula in the roof of the mouth. The Mosé sign is the bobbing or nodding of the head. The Mosé is a patient, not a doctor. The Mosé, at that time, Leutic disease is common, and it's a common cause of aortic incompetence. The Mosé is a visible or bobbing or nodding of the head movement. Evaluation of aortic regurgitation, chest X-ray, enlarged cardiac shadow, and aortic root enlargement. An echocardiography evaluation of the aortic valve and aortic root with the measurement left ventricular dimensions and function is the cornerstone of decision making and follow-up. Aortography used to confirm the severity of aortic disease. Management of aortic regurgitation, generally infective endocarditis in high-risk dental procedures of aortic valve or history of endocarditis, of history of the aortic valve prosthesis or high-risk procedure give infective endocarditis. Medical vasodilator and AC inhibitor, nifedipine, improves stroke volume and reduce regurgitant volume, and given only if the patient is symptomatic of hypertension. Serial echocardiogram to monitor progression. Surgical treatment is definitive treatment of the severe aortic regurgitation. This flow chart is very nice flow chart. Diagnosis of aortic regurgitation. If it's acute, as we said, right away refer to the surgical theater and do aortic valve replacement. If it's a chronic, if it's mild or moderate aortic regurgitation, not severe, serial follow-up, and by the echocardiography sign and symptoms monitoring. Let us go to the severe. If the severe symptomatic, right away do aortic valve replacement. If no symptom, do exercise. If it's positive, do valve replacement. If it's normal, do LV function by echocardiogram. If it's reduced ejection fraction, do replacement. If it's normal, normal ejection fraction, do dimension. I mean left ventricular and diastolic systolic, systolic dimension more than 50-55 millimeter, or left ventricular and diastolic more than 75, do surgery. In the case of the chronic, mild to moderate, in follow-up, if measurement becomes, this measurement, do surgery. If it is left ventricular and diastolic, 45, 50, or 60, 70, continue on the follow-up on medical treatment. In simplified indication for surgical treatment for aortic regurgitation, any symptoms at rest or exercise, do surgery. Asymptomatic treatment, if ejection fraction drop below 50 or left ventricular dilatation. This is a picture to see dilated and the cardiomegaly, left ventricular enlargement, and the aortic root enlargement too. This is the first picture in our lecture, and this is the transesophageal echo to see three cusps. This is the left coronary cusp, right coronary, non-coronary cusp with the severe aortic regurgitation. Is that the transesophageal with the regurgitant volume. Thank you and see you soon.